بسم الله الرحمن الرحيم. كل سنة وحضراتكم جميعا طيبين. First, let me introduce myself. I am Sharif Abdul Wahab. I'm a professor of clinical oncology at Shams University and head of board of trustees of Advanced Integrated Cancer Foundation, AICF. On behalf of AICF and the Arab African International Cancer Congress, AICC, I would like to welcome all of you, dearest colleagues and friends. It's my pleasure and honor to see you all today in this virtual meeting, and special thanks to Amgen for their continuous support. Today, we are happy and pleased and honored to have our dearest Professor Ignacio Gelbazo from Spain, and he will give us a lecture about NCCN supportive care update. May Allah bless all of you and your families. Please, Professor.
Good afternoon, everyone. Thank you very much for having me, and thank you very much, Professor Zarif, for the kind introduction. I'm going to try to review and summarize some of the key aspects that the NCCN guidelines have just provided about the management of cancer patients in this new era in which we are. These are my disclosures. So first, I will try to make just a brief introduction to the SARS-CoV-2 or the COVID-19 disease. We will also review some challenges in the healthcare for cancer patients in this situation of the pandemic. Then we will drive our attention to the NCCN recommendations, and I will also provide some practical tips from our experience at the University of Navarra in Spain, since you know that Spain has been one of the epicentrics here in Europe. So, as you probably all know, this started to be as a disease characterized by a pneumonia in patients, in many of them as a severe pneumonia of unknown origin. So, of course, this was the first case was seen in November 2019 in China, in Wuhan city, and there was a very rapid suspicion that this pneumonia may be caused by a coronavirus or a new virus, such as the SARS viruses that we knew already. However, it wasn't until January 11th that the novel, what it was called the novel 2019 coronavirus genome, was released. And you can see here some of the data and how the complete genome was available. So that started a very important thing, which is that potential drugs against this virus and also the vaccination process to develop vaccines against it were able to start due to the better knowledge about the virus. So the virus was called SARS-CoV-2, and the disease is the CoV or the COVID-19, as we call it now, according to recommendations from World Health Organization. So if you look at the right-hand table, you see that there has been in the past other similar viruses out there, many of them or most of them coming from China and also coming from animals. Bats or pigs are the most common animals hosting these viruses on a regular basis, and but it can also be camels or cats or any other animal. So when those animals are manipulated, and especially if you are eating those animals, you may contract the disease. So SARS-CoV-2 virus was likely transmitted from bats to other animals. This is still something that needs to be still proved. But however, we have a lot of evidences that this is the case. And the most important thing is that not only animals can be infected from bats, but also from other animals or from bats. People can also contract the disease, as you can see. So this virus is spread from person to person, mainly due to the mucosa and because of the droplets that the oropharyngeal region are able to produce when talking or when coughing, for example, right? So whatever droplets in surfaces, in hands, in any material, which actually can last for a couple of hours until a couple of days, can be transmitted to other people by physical contact, or just touching some materials, or just picking up the phone, or opening a door. So this is why this virus is so infectious, and the infection rate is so high, and it has actually spread all over the world in really only a few weeks. So something that it was difficult to think of from the very beginning was how severe this condition may be. And if you remember, probably, and this has happened probably in every country, we were in Spain looking at Italy or China, and we didn't really believe that was going to happen also here in Spain at the same degree. We were first thinking that probably Chinese people, because of their habits, might be more prone to contract the disease or to spread it. We thought that that would never happen here. Some assumptions also made from the very beginning was that probably this was more or less like a flu. So we knew, well, every year we have some thousands of people dying of flu in the world, and that is something that doesn't actually stop the country or doesn't make us things differently. However, and this is important, this new virus has been shown to be mild in probably the majority of the people that contracts the virus. However, it can be severe in up to nearly 15%, and critical, so those patients actually needing an intensive care unit and respiratory support, is about 5%. And this is important because if the numbers are low, this is not a deal. You can actually cope with this in every country with a health system that is able to admit patients to the hospital, treat them accordingly, or hosting them in the ICUs if needed. The problem is that when you have so high numbers of people contracting the virus, just 5% of those 200,000 people, for example, or millions of people, is something that you just cannot cope with, because you don't have enough respirators, you don't have enough ICU beds in your country, and the system just collapses. And this is probably the most important part of the problem that nobody was able to foresee. And this is why it has happened in every country, and only few countries have been able to anticipate the problem, to really believe in the threats, and put in place the necessary conditions and solutions for avoiding this to happen. So this is as of so it might have probably changed a little bit from yesterday to today. But if you look at the number of cases, or the million of cases per country, there are really differences. This is probably due to different aspects, and one which is important is reporting. So testing and reporting. So not in every country all suspicious patients are tested first, and if they are tested, not always they are reported. So this is important because the numbers may really vary from country to country, and that doesn't really mean that some countries don't have cases at all or have few cases. It could be probably just because you don't really know how many patients are, right? However, as you can see here, Western Europe and North America are, apart from China, of course, have been really severely affected by the virus. And this has really become a pandemic and a first category health threat for all patients. If you look to some countries, you can see Spain and United States at the very top of the list, along with Italy and some other countries. If you look at the bottom, you see Egypt only a few cases as compared to other countries. So probably the impact of this disease has been different, as we already mentioned, according to different populations and areas. The climate is also something that could have an impact, although we don't really know what impact is that. And it is true that some countries with warmer conditions at this time of the year have still suffered very strongly from the virus. So again, if you look at the deaths, for example, United States is around more than 40,000 deaths already, and Spain is more than 21,000. So these are just unacceptable numbers. Every death is unacceptable, of course, but these numbers are just really something that unprecedented. So it is true that the evolution of the epidemic or the pandemic is different according to different countries, and this is due to first the time where the virus actually hit the country, the first case that appeared, and there has been around 2 months or more than 2 months from China to other countries, for example, and from Spain or Italy to other countries. So this means that some countries are already seeing decreasing cases, such as Italy, Germany, France. In some other countries, not shown here, such as Spain, or United States, we are not really seeing a real decrease in the number of new cases. And some other countries, such as Egypt, are places in which new cases are still increasing. So some are decreasing, some are just not changing, and in Egypt or other countries, probably because the peak has not been reached yet, are still increasing. So we don't really know the final numbers for any of these countries. This has really changed the way we think of life, or the way we used to think of life in a globalized planet, right? So if you look at the airports in the United States, for example, JFK, this is just something amazing that we haven't seen before. If you actually look at different very touristic spots in different places, such as London, Madrid, or New York, you can see the previous and the now. Well, this has changed actually. This is now and this is the previous, but you can see how this has changed dramatically. And confination is actually something that is happening in mostly every country already, with different measures, but still. Okay, what challenges do we have in healthcare for cancer patients, more specifically during this pandemic? Well, first, I would like to show you something that probably you all know. If you remember, maybe some of you actually were in Madrid in 2014, or previously for ESMO Congress. Actually, this year, ESMO Congress was still planned to happen in Madrid again. And but at the same place this was going to happen and happened in the past, this is what we have now. So this is the Madrid fair. And this is how in a couple of days, actually this fair facility converted from a fair facility into a more than 2,000 beds hospital. And this is just amazing. This is something we have never seen before. And this has happened also in the United States, in UK, and so many other countries, especially in China, showing that we were really overwhelmed by the pandemic and we didn't have enough beds. Actually, in my hospital, it's an institution that has two sites. One site is located in Pamplona, which is the place where I'm currently, but the other site is in Madrid, city center. And we actually had to send beds from Pamplona to Madrid to be able to cope with the new patients incoming to the hospital. So we had to triple the number of beds to accommodate all patients, and we have to more than double the number of ICU beds also. So this has something changed the way we do things. So the most important challenge, I would say, in this situation is first try to protect patients, and at the same time try to protect patients by protecting professionals. These are some of the professionals in Italy, for example, that has died, and this has been published a couple of days ago. And but there are too many others, and this is also the case of Spain. So it is important to remember that according to different data from different countries, from 5 to 10% of all confirmed COVID-19 positive patients are healthcare workers. In Spain, it's actually higher, 16%, which is, again, unacceptable. Probably the low knowledge of the virus from the very beginning, about the infection rate, the lethal potential, has contributed to the infection of healthcare workers. Actually, from the very beginning, we didn't really know what patients were actually suspicious, and we were treating them with no protection at all. At the same time, personal protection equipment shortages have also had a crucial role in this probably contamination of professionals. And this is the case of Spain, but many other countries also. At the same time, no massive PCR tests have been provided to professionals anywhere. Only in some countries in Northern Europe, such as Germany or Switzerland, but not for many other countries. So some professionals have a delay in the diagnosis and in using protection masks or washing hands, etc. It is important also to remember that even though you are asymptomatic, you can still be infected and actually be contagious to other people. And this is something that we saw by the end of February, that no cases were actually reported in Spain so far. We had some professionals that came from some countries such as Italy and China, and they were finally tested to be positive. But from the very beginning, we didn't have any case in Spain. So those professionals were actually contributing to the dissemination of the infection in patients and other professionals. And this was really something important. So healthcare professionals have also put their families at risk, because you are in contact, you are exposed to the virus and to other patients or other professionals, and you are not confined at home. You are coming to work every day to the hospital, so you are also putting your family at risk. This has actually driven some areas in Spain, most of the big cities, to open hotels that were close to the tourists to professionals, so you can go to a hospital, to a hotel, and not to come back to home every evening after work from hospital. But this is also something that we have to take care of, which is the safety of our cancer patients. And this is just some of the patients that we've seen dying in the last couple of days in Spain. And this is kind of tribute that was published in a newspaper, national newspaper in Spain a couple of days ago. So here we have to take into account first that in a Chinese retrospective study with more than 1,500 cancer patients, they showed a higher risk of COVID-19 for those cancer patients. Okay, so this was probably due to frequent visits to the hospital. And in another prospective trial, with more than 1,500 COVID-positive patients, only 1% had history of cancer, being lung cancer the most frequent. However, cancer patients showed more clinically severe events, and this is important. Chemotherapy or surgery in the past month also associated with clinically severe events. Prognosis also worse for patients, cancer patients with more than one chronic medical condition, which is something that normally happens in our patients. So what about the NCCN recommendations? So this has driven NCCN to try to drive medical oncologists to create a way of doing things differently in order to protect patients and other professionals. The first thing they recommend is to create a unified command in every hospital with different people in charge of every different aspect of the logistics that needs to be put in place. Second, it is important to consider that only essential visits have to take place. You don't have to make your patients come to the hospital for every kind of visit, only essential visits. What are essential visits? Well, those patients under systemic therapy, such as neoadjuvant, adjuvant, or maintenance, those patients, especially with a curative intent in their treatments, should continue their treatments. And this is important. So those patients need to come to the hospital and you need to protect them. It is something more controversial to consider patients under palliative care if they need to come to the hospital or not. For that purpose, you really have to put in place another consideration, which is the risk of your specific patient. Probably females with no other conditions, young females, for example, never smokers, no lung conditions, no hypertension, probably are also able to continue their treatments. Some other elderly male smokers, hypertensive patients shouldn't be receiving treatment at this point. What about the non-essential visits? So those patients, those visits are those patients under follow-up programs. So those patients with no evidence of disease, patients in complete response, those patients should not come to the hospital. And in those patients, you can do two things. One, to reschedule the visit to postpone it, or to create telemedicine system. You will see how we have done that in our hospital. The second important thing they consider is that 1 to 2 days prior to upcoming visit, you have to try to pre-screen all the interventions that you're going to do in your hospital. So you call the patient, or the patient uses an app, and there's a questionnaire and a formulary that the patient actually has to answer. And according to the symptoms that the patient has, dyspnea, cough, fever, etc., or not, or mild symptoms or moderate symptoms, you recommend those patients to stay at home and to do close phone monitoring, or you can consider those patients attending actually a screening clinic because they might have a risk of developing pneumonia, or they already have developed pneumonia and you need to treat them. And at the same time, you have to do a risk assessment according to hypertension, obesity, respiratory conditions, heart failure, etc. And according to that, when those patients actually enter the hospital, on the right-hand panel, you have to monitor fever again. You have to re-ask the patients to fill in a form. And according to that, you may have a red traffic light. That means that the patient is probably suspicious of having the virus, and you need to refer that patient to a screening clinic that can be on-site or off-site, but it has to be absolutely out of the normal circuit of COVID-free patients. It could also be that there is a yellow light and those patients need further triage, or a green light, which means that the patient can actually enter the normal hospital and continue this circuit. So for those patients, you have to make risk assessment of pros and cons for treatment in cancer patients. You need to test all patients before any interventional procedure. This is important, especially those undergoing surgery or bronchoscopies. Remember that the virus is going to be in the nasopharyngeal area. If you make a bronchoscopy, for example, or intubation, you are going to put that virus down there in the bronchi. You don't want to do that, okay? So you could also consider to perform CT-guided biopsies instead of endoscopic procedures, or consider liquid biopsies, if validated, instead of an interventional procedure. Try to limit or avoid visitors. Patients should come alone or only with one visitor to the clinic, and avoid those suspicious visitors to enter the hospital. No active treatment against cancer for positive patients with pneumonia should be advised. In positive asymptomatic patients, elective surgery treatments should be avoided also, especially if orotracheal intubation is expected. Of course, if there is an emergency, you have to operate on the patient, taking all the measures to protect the patient and the professionals. But if elective, you should stop and not continue. In positive asymptomatic or mild symptomatic patients, radiotherapy can be continued, but after a specific in a specific circuit, so not together with other patients that are COVID-free. And you should consider hyperfractionation radiation regimens. You should increase evaluation image techniques intervals, so don't make the patient to come every 2 months. Maybe you can consider 3 months for a new CT scan, because you don't want the patient to come all the time to the hospital. According to systemic therapy, and this is important, you can provide chemotherapy, but you should consider changing to equivalent oral formulation when that is possible. Targeted therapy would be advised, because you can actually prolong the intervals and keep the patient at home receiving the pills. Immunotherapy is something that is under investigation, but some schedules of immunotherapy can actually be more prolonged, the intervals, if you double the dose, for example, nivolumab in lung cancer. Okay, always consider using growth factors, and this is important because those patients receiving chemography may present febrile neutropenia, and if that happens, that is a real mess, because those patients need to go to the emergency room, which is going to be completely packed of COVID positive patients, and apart from that, those patients may be at a higher risk of developing more severe pneumonia. Can we administer treatment at home? Some drugs, especially hormone therapy, can be administered at home. Clinical trials, new patients for enrollment should be stopped, and bone marrow transplantation has to be considered only for really urgent cases. When those patients are actually tested positive, cancer patients, when can you resume cancer treatment? At least you have to have 2 sequential negative PCRs in order to start again the treatment, and respiratory symptoms must be resolved and no fever. And if you don't have testing capabilities, at least 2 sequential, sorry, this is not the case, you have to consider patients at least 28 days after the PCR was positive, okay? And all symptoms have to be disappeared. And just to finish, try to protect professionals by shift planning. You can keep some professionals at home, enabling telecommuting for some patients, some professionals that can work from home. Use the adaptive protection face masks and wash hands. This is important. PPE in suspicious and confirmed cases must be worn all the time, and only essential healthcare workers enter in patients' rooms, no other workers, and try to avoid potential professionals meetings, not to you don't have to perform multidisciplinary meetings or department meetings with all the people all together at this point, just video conference. And professionals with any concerning symptoms have to stop working and be tested and not return to work until everything has been cleared. So these are the PPEs that we use here in my hospital at the ICU units. Before returning to work for those professionals that have been tested positive, so at least 2 consecutive tests negative and all resolution of symptoms. If you don't have the option to test the professionals, return to work at least 3 days following resolution of fever without the use of medications and improvement in respiratory symptoms, and at least 7 days have passed since symptoms first appeared. This is again a summary of how to protect patients, as we mentioned before, and how to protect also healthcare workers. So for existing cancer patients, you have to reschedule visits, or you have to transition to telemedicine in those patients in which we can do. And this is how we have done it here in my hospital. This is my institution in Pamplona. So this area here in red is the COVID area. So we have used all this part of the hospital for the emergency room, for admitting patients to hospitalization, ICU units, etc. And this is how it looks like. And this is all the COVID-free area. So we have been able to still treat our patients with other conditions in the general hospital outside the COVID area. And this is important, but you have to be sure that both patients and professionals are not changing from the COVID-free to the COVID area, because you may be spreading the disease. You may also put some signals or restrictions to the use of some of the elevators or other systems in order to protect patients from the COVID-free to the COVID area. And this is the telemedicine implementation that we have done using this platform. So you can see here all the patients that I have to make a phone call or a video conference, and I just press here and I call the patient, and the patient appears, and I can try to manage how the patient is doing. This is our electronic healthcare record system, and these are the patients hospitalized for oncology. And look here, this is something, an icon that we have put in place showing that the patient is COVID-free, because we have tested the patient because of suspicious symptoms. So if it is red, that means that the patient is positive and the patient has to be hospitalized in the special COVID area. If it is yellow, they are still in that area, but that means that you don't still have the results from the PCR. That can be 4 to 12 hours depending on the day. And if it is green, that's the only situation in which you can enter and see the patient with normal equipment. And this is just a case, just to finish up, showing this is a patient of mine that was treated with surgery for lung cancer, and this was in 2018, and this is November 2019. Last follow-up, he was doing well. And in March 19, he developed fever, diarrhea, and dyspnea. A brother-in-law of his was COVID positive, and in March 27th, he was admitted to hospital with 88 percentage of oxygen saturation. There was a unilateral pneumonia, as you can see here, and he was tested positive. So he was entered in the special area. By March 29th, there was a bilateral pneumonia and respiratory distress syndrome. So he had to enter the IC unit, and orotracheal intubation was needed. In April 6th, was extubated, and a second PCR was still positive. So he remained there. And in April 20th, after 3 more PCRs that were negative, the patient was transferred to the normal hospitalization unit, and he's expected to be discharged tomorrow. So the patient, yes. So this is the treatment that the patient received: hydroxychloroquine, azithromycin, and lopinavir, ritonavir. And this is how his different X-rays develop. And in conclusion, protecting patients and healthcare professionals is a must. It is crucial to create a COVID-19 free hospital if possible. Consider always reschedule telemedicine when possible. Pre-screening strategies are necessary to determine what patient can actually attend or must be tested. Cancer patients should continue receiving their treatments if possible, but you have to take careful messages. Test all suspicious patients before entering the COVID-free clinic. Test all patients before interventional procedures. And just to end, professionals should also be protected. Telecommuting when possible. Establish shifts to protect personnel and not to expose all at the same time. Provide protection materials and PPEs for those professionals managing actually positive or suspicious patients. Provide rapid testing for professionals with symptoms, and do not return to work if not recovered. So thank you very much, and I will be happy to take any questions.
Aywa. Okay. Okay. Thank you so much, Professor Nacho, for this nice presentation. And may God bless you, Spain, Egypt, and the whole world. Of course, this is a nice presentation about the situation in COVID-19 and this pandemic. We hope from God that everything will be okay for the whole world. And now the platform is open for any question for Professor Nacho. Any kind of questions? Okay, from my side, of course, Professor Nacho, can you hear me?
Yes.
Madrid, I think that the situation is better than in Barcelona, but still, I think you are taking the procedure, all the preventive. But what about the use of the growth factors? Because this is my lecture will be the third lecture, and then we are opening the questions. But what about in Madrid? What are you using about the growth factors? I mean, for the anemia, for neutropenia, for etc. So, do you have any experience with this?
Yes, we have been treating all our patients under chemotherapy in this situation with growth factors for everything, especially those at a higher risk. This is really important, because those patients, when they actually have a problem with neutropenia, with a severe anemia, or with any other problem, they need to attend the hospital. And the hospitals just cannot cope with the number of patients which are COVID-free, because this is apart from the patients which are COVID positive. So you have to take into account that, especially in Madrid,
most of the hospitals have been completely full of patients with the virus, not being able to treat or attend in the emergency room any other kind of patients, only patients with a car accident or things like that. So if you don't want your patient to go to the hospital for these conditions, you really need to prevent. And growth factor is crucial for preventing that. Other option would be not to treat the patient, but as we just mentioned, that is not an option for many patients with a curative intent. So you need to try to resume treatments, but protecting those patients by providing growth factors. And this is something that has been clearly recommended by the NCCN guidelines.
Thank you so much, Professor Nacho.
Okay, so let me please introduce you to Professor Sherif Abdelhaweb. He's Professor of Clinical Oncology at the Ain Shams University, and he's also the head of the Board of Trustees of the AICF. So for me, it's a great pleasure to introduce him. He's going to be talking about the impact of COVID-19, especially in this situation with the growth factors and how we should use these factors for our patients. Thank you very much.
Thank you, Professor Nacho, for this kind presentation for me. Welcome again. We are talking about the impact of COVID-19 on cancer patients. And of course, all of us know that the pandemic of COVID-19 is a big shock for all people all over the world, including even the developed nations. And this showed how much burden to the health system and to the economy as well. Therefore, in cancer management field, we have to set a new guidelines for our practice. This will, of course, influence the health services, but it will at least preserve the minimum requirements. And all cancer societies have talked too much nowadays about the pandemic, and each society released their own recommendations and guidelines. And here we try to summarize the most important tips, especially from the top international cancer societies such as ASCO, ASH, ESMO, and NCCN. So this is the executive summary for the tips that all healthcare providers are to implement preventive measures to minimize the infection spread and adhere to the strict requirements surrounding proper use of PPE or personal protective equipment. And whenever possible, physicians should telemedicine to provide appointments for patients, as Professor Nacho mentioned before, and to limit the travel to the clinic sites and hospitals. And if possible, physicians should consider altering treatments to minimize patients' trips for medication administration, or in other words, that to shift from IV to oral or subcutaneous therapies whenever possible. And if possible, the use of therapies such as established immunosuppressive effects should be minimized as soon as possible. Regarding the recommended guidelines to the supportive treatment of cancer patients have been changed during the pandemic of COVID-19, and even for anemia in the light of potential for the blood shortage in the blood bank with the COVID-19 pandemic, we suggest in the short term broadening the use of erythropoietin stimulating agent therapy plus or minus IV iron supplementation to manage the anemia in patients with malignancy requiring blood transfusion support. While for neutropenia, which is a very common side effect for the chemotherapy, please think about to expand the prophylactic use of GCSF to minimize the risk of febrile neutropenia, thus not adding to the overwhelming number of cases in the emergency rooms and the hospitals. And here we have a change in the threshold of the use of GCSF with regimens from only from high-risk patients for febrile neutropenia to the intermediate zone of 10 to 20% risk factors for febrile neutropenia. And finally, as regards the thrombocytopenia, there is a change in the consideration by lowering the threshold for transfusion when the platelet count is below 10,000, and some centers using the limit of 20,000 for the platelet count, and consider adding the prophylactic antifibrinolytics for patients with platelet counts under 10,000. Again, avoid transfusion as much as possible and go to the use of thrombopoietin-like agents such as Inflate. Thank you for the first lecture. Any question?
Yes. I have a question. So what is the situation in Egypt right now, according to this COVID-19? And how are you facing this? Because there are real differences from one place to another, from one country or continent to another.
First, thanks to God, of course, that we really facing the COVID-19, but in a better way from Western Europe and China and USA. Actually, the number of cases that reported by the Ministry of Health is very minimal, because maybe the climate, as you mentioned before, that the hot climate may be limiting the spread of infection. And the government took many preventive measures. Like in the hospital, we diminished the number of cases that we are accepting per day in the clinics. And for a shorter duration of working, even the banks, they are closing earlier than before and for a shorter duration, and they are limiting the number of the people inside the bank itself, and the waiting area is outside in the air, the fresh air. And even there are multiple of the governmental, like the traffic, they are closed for a while until the control of the number of cases. Of course, we have a curfew, but it's a partial curfew. It's not complete lockdown. We have starting from 8 o'clock in the evening, closed until 6 a.m. And this limits, of course, the people, because here the hot climate, always people are working afternoon and in the evening, and they are going to the shopping malls or in the cafes or the restaurants. And the social events in the evening is the most common, not during the day. So this governmental measures really restricting the number of cases, and we hope that we had reached the peak of the cases, or about to reach the peak of the cases, then the decline of the curve. Maybe we have theories about the BCG vaccination for tuberculosis, which was obligatory in the country maybe 50 years ago till now. And there is a theory that this BCG vaccination may be immune modulator for protecting against COVID-19. And we wish, of course, that this theory is working.
Mm-hmm.
Any kind of question about this? Thank you. And this is the third lecture today and the final lecture about management of febrile neutropenia and the role of the myeloid growth factors, and especially on spot on pegfilgrastim or Neulasta. And here in Egypt, we call it Neulastin. And this is the agenda for the lecture, which will go into this items on the screen. And here, febrile neutropenia can be defined as fever in presence of neutropenia. And fever is the oral temperature of 38.3 degrees Celsius as a single measurement, or a measurement of 38 degrees Celsius for more than an hour. In presence of neutropenia, which is a neutrophil count below 500, or neutrophil count of 1,000, and predicted decline less than 500 over the next 48 hours. Febrile neutropenia occurs mainly because of bacterial pathogens rather than fungal, viral, or protozoal infection, which can occur as secondary events. And in about 30% of febrile neutropenia episodes, an infectious source could be identified. About 80% of identified infections believed to arise from patients' endogenous flora. In this registry study, the diagram showed that the higher incidence of febrile neutropenia mostly occurs during the first 3 cycles of chemotherapy. And look at this, about 11% of patients treated with chemotherapy across all types of cancers treated, they developed the febrile neutropenia during the first 3 cycles of chemotherapy. And here are these incidences of febrile neutropenia in different types of cancers after treatment with chemotherapy. Febrile neutropenia is a fatal disease or a fatal event and a very grave disease. And of course, it necessitates the hospitalization. And during a study between 2007 and 2010, the mean length of stay in the hospital due to febrile neutropenia was around 9 days across all types of cancers, and reached up to 10 days for those patients who are treated with chemotherapy because of non-Hodgkin lymphoma. And of course, the hospitalization costs too much money. And nowadays, during COVID-19, hospitalization, of course, is very dangerous, and we are afraid of the hospital infection itself. So a study was done between 2007 and 2010 to estimate the cost of the hospital stay, and they found that around $19,000 during that time, which must be higher nowadays, that the patient cost for hospitalization across all cancers. But look at the ovarian cancer patients who developed febrile neutropenia and needed hospitalization, and the cost was around $25,000. And even here in Egypt, you can say that hospitalization for 9 days might cost at least 30,000 Egyptian pounds, if not more. And in the same study, the incidence of mortality due to febrile neutropenia was around 11% across all kinds of cancer, and reached up to 16% for those patients suffered from non-Hodgkin lymphoma, which makes febrile neutropenia as a fatal event. In a study in 2009, sponsored by Amgen, they found that chemotherapy-induced neutropenia was the primary cause for dose limiting or dose reduction and treatment delay. And in this study, we included the early stage breast cancer and aggressive non-Hodgkin lymphoma, and around 60% of patients with breast cancer or non-Hodgkin lymphoma had treatment delay and dose reduction because of neutropenia-related events rather than other causes. There is a term called relative dose intensity, or RDI, and in this study was published in GCO in 2004. You can see that 56% of patients treated for breast cancer had treated with chemotherapy with RDI less than 85%, and 48 patients with non-Hodgkin lymphoma had been treated with less than 85% of RDI. And logically, reduced RDI will be associated with worse overall survival in early stage breast cancer. And look at the Kaplan-Meier curves, where the patients who have been treated with RDI more than 85% had better outcome as regards the progression-free survival and overall survival. And the same, and overall survival, this is the Kaplan-Meier curve for patients treated with R-CHOP for non-Hodgkin lymphoma. Look at this, patients who had been treated with higher RDI did better in terms of overall survival than patients who had been treated with lower RDI. The same for patients treated of high grade of non-Hodgkin, of course, and 85% was measured as the mean RDI. Now, Amgen conducted what's called LEARN observational trial by Spanish group. They randomized patients of different solid tumors and hematological disease, and they randomized into two groups. One group received once injection of pegfilgrastim versus the other arm received the daily injection of filgrastim, and the mean number of injections was 5. And the analysis criteria included the febrile neutropenia incidence, hospitalization due to febrile neutropenia, and the use of antibiotics. And for analysis for this trial showed that the rate of dose reduction of chemotherapy due to neutropenia was decreased by the use of pegfilgrastim versus the daily G-CSF. The incidence of febrile neutropenia was decreased by belfilgrastim. The proportion of patients needed hospitalization and the use of antibiotics due to febrile neutropenia was diminished because of the use of pegfilgrastim rather than the daily injection of G-CSF. Another collection of data of 11 clinical and observational studies was done using the pegfilgrastim primary prophylaxis, 6 milligram as once injection in all cycles, or the use of current practice where some of us don't use G-CSF as a prophylaxis or giving G-CSF accordingly in any cycle, either daily injection of G-CSF or pegfilgrastim. Most patients treated with docetaxel-containing regimen, and the primary outcome measure was the proportion of patients with febrile neutropenia across all cycles. The secondary outcome measures included the proportion of patients with febrile neutropenia in cycle 1, the hospitalization because of febrile neutropenia, the incidence of chemotherapy dose delay and dose reduction, and grade 3/4 hematological toxicity. Look at these results. You'll see that the use of pegfilgrastim as primary prophylaxis led to decreased incidence in the incidence of febrile neutropenia across all cycles. And even after the first cycle of chemotherapy, there is a reduction of the incidence of febrile neutropenia by using pegfilgrastim. And here we can see that neutropenia complications, including dose reduction or dose delay and the use of antibiotics, decreased significantly by the use of primary prophylaxis by pegfilgrastim. Balducci et al. In 2007 have a publication in Oncologist, and they found that the incidence of febrile neutropenia during the first cycle across all cycles of chemotherapy was significantly lowered by the use of PPP or pegylated or pegfilgrastim primary prophylaxis. That was beside the lowered incidence of hospitalization, and the overall incidence of febrile neutropenia was decreased by using pegfilgrastim more than the use of per cycle filgrastim. The pegylation for the molecule of filgrastim resulted into a molecule that is large, which is difficult to undergo the efficient glomerular filtration and renal excretion. Therefore, retained and prolonged action. Thus, the administration became an easy procedure as once per each cycle of chemotherapy. The recommended dose for pegfilgrastim is 6 milligram once subcutaneous injection per each cycle of chemotherapy and should be given 24 hours after chemotherapy. And please note that it should not be injected 14 days before the next cycle. Therefore, as a summary for the use of Neulastine, it should be injected 1 day after chemotherapy and could be given 3 to 4 days after chemotherapy. Used as a single agent per chemotherapy cycle, which is the recommended dose. And this will lead, of course, to decrease the hospital stay due to neutropenia or febrile neutropenia and allow the administration of those dense regimens and shorten the duration of neutropenia. And now coming to the NCCN guidelines according management of neutropenia, and you can see that the panel recommends evaluation of each patient prior to the first cycle of chemotherapy. And you can calculate the risk factors, which include the disease you are treating, the type of chemotherapy regimen you decided either as a high dose, dose dense, or standard dose, and the patient factors, and your treatment intent either curative or palliative. So if you have patient with low risk for febrile neutropenia or neutropenia less than 10%, then no G-CSF is needed. While for those patients with high risk of getting neutropenia or febrile neutropenia, then G-CSF is advised as category 1 recommendation. And at that time, in the normal situation, the intermediate zone of the high risk, risk factors for getting neutropenia or febrile neutropenia between 10 to 20%, then consider G-CSF. But this have been changed nowadays because the intermediate is considered as a high risk. Then G-CSF is recommended. Intermediate in the normal situation, intermediate risk patients should be assessed for patient risk factors. As patients who had been treated previously with chemoradiotherapy, or patients with persistent neutropenia with bone marrow involvement by the tumor, or patients with liver or renal dysfunction, and those who are elderly patients receiving full course dose density. Then if you have patient with no risk factor, then no G-CSF is needed and just observe the patient. If there's risk factor even more than 1%, please consider giving G-CSF and evaluate the patient prior to second and subsequent cycles of chemotherapy for febrile neutropenia or dose-limiting neutropenic event. If it occurred before and the patient used prior use of G-CSF, then the patient must be have a dose reduction or change in the line of treatment or the protocol or the treatment regimen. If there is no prior use of G-CSF, then you have to consider giving G-CSF. For those patients with no febrile neutropenia or dose-limiting neutropenic event, then repeat assessment for each subsequent cycle. In our daily practice, we can see patients with febrile neutropenia and who is receiving or received prophylactic G-CSF. And if the type of prophylactic filgrastim is used, then you should advise to continue G-CSF. If the patient received pegfilgrastim, then no additional G-CSF is advised. While those patients who did not receive prophylactic GCSF and no risk factors for infection, then no therapeutic myeloid growth factors is advised. But if there is if there is risk factors for infection, then give therapeutic myeloid growth factors. For those patients who had been treated with radiopharmaceuticals and developed myelosuppression, then therapeutic MGFs are recommended. The following slides will show you the examples of chemotherapy regimens and the level of the risk for febrile neutropenia. And here are the most commonly used protocols for breast cancer treatment. And you can see that most of them carries a high risk for febrile neutropenia or infection. The same for patients who are treated for non-Hodgkin, and this is the example for most commonly used chemotherapy regimens for treatment of non-Hodgkin lymphoma. And you can see that most of the regimens carry between intermediate to high risk for febrile neutropenia or neutropenia and infection. Finally, in our practice, we always notice an associated pain after injection of myeloid growth factors, and including the pegfilgrastim. The pain may be attributed to release of histamine, which is involved in the inflammatory process. And non-steroidal anti-inflammatory are usually don't give benefits. Therefore, prescribing antihistamine may be valuable to a certain extent in managing such a pain, with special valuable data about the more effective drug, which is loratadine or claritine, which can be used as a prophylaxis. And finally, save the date for 8th and 9th October this year, inshallah, for the mega event AAICC in GW Marriott Cairo. And we hope the safest situation for the whole world, and to see you in Cairo, inshallah. Thank you so much.
More than a question, but is regarding what you just mentioned, and I think it's important to stress the fact that many patients with active cancer currently are using more and more schemes of therapy that include the combination of chemotherapy and immunotherapy. And one of the things that we know from those combination regimens is that those are more likely to produce febrile neutropenia. And this is important. In my experience in lung cancer, I see it all the time. We are using combination chemo plus immunotherapy for first line non-small cell lung cancer, also for small cell lung cancer. And the rate of febrile neutropenia are really high for those patients. And it is really important to stress the fact that we really need to keep those patients safe by providing them with the growth factors in advance, because otherwise most of those are going to be developing, and you are putting at risk not only the life of the patient, but when they do well, you are putting at risk the continuation of the treatment and the dose density of the treatment, and this is important. So thank you for your very nice presentation, and I think it's important to stress the fact that patients need to be protected, especially when the regimens are more likely to present these complications.
Thank you. I have a question for you about what you said about giving both chemotherapy and immunotherapy at the same time, and during this pandemic of COVID-19. Do you think that we have to think about giving either one of the agents, either immunotherapy alone or chemotherapy alone, to avoid the combination, and maybe it carries more side effects and more toxicity as regards hematological toxicity, especially for neutropenia and the higher incidence for febrile neutropenia? What do you think that we divide the patients and to see what is the best for patients, either for chemotherapy alone or immunotherapy alone? Of course, you know, I you talk I know that you are lung specialist, so most of the regimens nowadays for lung either as a targeted therapy or immunotherapy. So what do you think about this?
This is a very relevant question because it is true. Sometimes you consider what to do. And for example, it is true that you really have to consider the specific risk of your patient. So it is not the same that old, patient with prior conditions such as heart failure or any other, or fragile patient with a bad PS that you don't really know how this patient may be performing after the treatment with the combination. So for those patients, you might need either to protect in advance using growth factors or to consider skipping the chemotherapy part from the very beginning. The problem is also that for those patients receiving immunotherapy, either alone or in combination, there is something that we are seeing in the COVID-19 era, which is that there are two phases in these patients positive. The first phase is the pneumonia phase, is something which could be very similar to other conditions, infections in the lungs. But the second phase, which is normally from 7 to 10 days after the pneumonia actually presented, those patients may have a really high inflammatory condition, which is called the cytokine storm, right? So for those patients, we see a colitis or pneumonitis or some other inflammations due to the really high inflammation system that those patients develop due to the virus. Right now I have a patient. He is in the hospital right now in one of our hospitalization beds because he is a patient with lung cancer being treated with nivolumab, second line. So he started developing cough, fever. He was tested. He was positive. He developed pneumonia, and we were able to treat that pneumonia, and he was well. However, now that has had passed around 2 weeks after he developed and passed the infection, he still has a very severe colitis. And we perform colonoscopy, we perform CT scan, and all his bowels are so inflamed. So we really started treating that patient with high doses of corticosteroids because we have seen that we cannot really rule out this is due to nivolumab alone or the virus alone or probably the combination of both factors. So he has these two risk factors. And with high doses of steroids, he's doing really well now. He's about to be discarded. But it's been like a mess to try to figure out why this patient was having this. So, probably you don't really have a good answer for doing one or the other. You have to consider a specific risk for each patient.
Thank you so much, Professor Nacho. And any question from the platform or from the audience? Okay, finally, thank you for this nice day, and thanks for dearest friend and dearest professor from Madrid, Professor Nacho, and wish you be safe, and to see you in Cairo, inshallah.
Thank you very much.
Thank you, everybody, and thank you for Amgen again.